Welcome to the All Things Physical Therapy podcast. This is your host, DPT Steph, your doctor of physical therapy, bringing you all things PT with an interdisciplinary approach so that you can be the best clinician that you want to be. Thank you for tuning into the All Things Physical Therapy podcast. This is Stephanie, your doctor of physical therapy, otherwise known as DPT Steph. On this episode, we'll be talking with Dr. Sanjay Juneja, a hematology and oncology physician. I'm so excited to have you here today, and to get us started, why don't you give us a little introduction about yourself?
Yeah, so I'm like you said, medical oncologist and hematologist down in Southern Louisiana. My wife and I both actually specialized in the same three things with internal medicine prior to our fellowships, and do that together in practice. And yeah, just really big on education and kind of the interdisciplinary approach with cancer, just because it involves so many things other than just beating the cancer, quote unquote. You really want to maintain lifestyle and empowerment and all, and expectations, I think, are a big part of that, so that you can really optimize those things. So passionate about that, and then that's kind of what I share on my TikTok handle and Instagram, is just kind of give more education on the processes and kind of just an idea of what's ahead. Because I think people can overcome really anything. I've seen it every day, just like people can overcome anything if they know what they're in for, and it's really humbling.
That's awesome. What made you, it's kind of a twofold question, what made you decide to go into medicine and then specifically like oncology, hematology?
So I actually wanted to be a middle school teacher for a long time. I had a really good one, and he just kind of made me see the world in a way, just broken down and mechanically, and kind of inspired me to like make sense of things, if that makes sense. And then I got into a pretty bad car accident in high school, and I lost my eyesight for weeks, really, and eventually got it back. But I was definitely like legally blind with all the treatments. And when people would ask afterward, like, why weren't you so scared that you'd never see again, and et cetera, I was like, it's weird, but I wasn't. And then when I thought, why not, I realized it's really was because of how much my ophthalmologist taught me along the way about, like, all right, Sanjay, this is what your pressure is. This is why this is concerning for this, type of glaucoma, and this is what your retina wrinkle is doing. And so he just gave me these mini goals, and it's kind of what I alluded to on the intro. Is just that, like, when you break something down and you know what to expect and what the next goal is, it really kind of just keeps you focused. So that's what inspired me, or made me realize that I could be a teacher while really equipping people with their health, which I think, just a little more important than somebody's own health, outside of their, relationships and those things. So, and then oncology was because I really felt like education is, in my biased opinion, like, is more important in that than anything else, because it's so psycho-emotionally derailing, and there's so much collateral involved other than just, quote unquote, shrinking the tumor. I mean, that's stuff we'll get into. I mean, the rehab, the physical conditioning, the optimizing to make them able to do the things they want to do. If you have to metastatic and you're buying time, like, what's the purpose if there's not these other things you're really optimizing? So I think because of that setting, it's just so intimate and sensitive. I felt like the education aspect was really one of the biggest cornerstones in that field.
I love that that's like one of your big takeaways is the education aspect, because obviously as rehab clinicians, I feel like that's something that we really hone on to, because yes, we can biomechanically help someone or make them, more successful in achieving functional goals. But the big component, like you said, that psychosocial kind of component of empowering someone to have them get to the point where they are able to do things mentally as well as physically. And I think that's something that I think in any profession or any field in healthcare is something that could really be truly powerful. What is kind of your day-to-day like? What kind of patients are you seeing? Is it a wide range of ages or diagnoses?
Yeah, so it's obviously predominantly older adults, because cancer is generally a disease of older patients, and by that I mean the longer you age, the more cell turnover you have, the more mutational error you have, and that just increases your chance. But of course, everyone knows, younger people that have those cancers as well. So I would say I'm exclusively adult. My residency was in internal medicine. I don't have any pediatric training. I don't think I could emotionally handle that actually, but so it's mostly, I mean, yeah, anything from 20s. I've had plenty of patients pass away in their 20s and 30s to, as high as 80s or even early 90s.
What has been one of your perhaps most challenging cases? Not necessarily like emotionally taxing, but I mean, just to kind of coordinate whether it's like a plan of care or just maybe there was a lot of medical comorbidities.
You mean in a patient in particular or in general?
Yeah.
Oh man, I'm. I mean, there's a bunch. Right now, there's one where, without giving away too much, basically they've done really well with their head and neck cancer, like a year and a half. It's been under good control. And then there was notice on restaging scans, there was a kidney lesion, and it just looked different. Then the head and neck tumor was behaving differently. So I biopsied that. And even though there were metastases to the thyroid and the adrenal, it turned out to be a second primary, which is more aggressive than the head and neck. And there's a few treatments that do kind of straddle both, but he already progressed on one that immune therapy that did both, so I couldn't use that. So it's just been challenging. And then there's there's also brain metastases in this patient, which are stable. We radiated them, but then you don't know if it's from the renal cell, which has a really high, uh, proclivity to go there, and head and neck just generally doesn't. So then, do I just stop the head and neck treatments on that, which already has lung mets, and now focus on the renal cells so that I can treat the brain better, or do I just radiate the brain and go straight with the head and neck treatment? So it's stuff like that. It's stuff that there's absolutely no guidelines, obviously, because it's not generally like, normal situation. And so you have those. I mean, you have a couple of those at any given time. But that's just one, I guess, active example this week.
Very interesting to say the least. And I think, I know from, so I've only been in practicing as a PT a little over a year at this point. And even though I work in acute care and I had an acute care affiliation in oncology, I think there's such a huge medicine side that we don't people don't realize like we have the knowledge of. And I like that you're talking about all these little parts because I think my listeners are going to be mostly in the rehab realm, but they're actually going to appreciate this kind of conversation because when you look at a patient's chart, whether you're in an outpatient or an acute care type setting, you're going to have most likely all of this past medical history. So it really kind of points out like, yes, they're originally a head and neck patient, but now you have all these other involved body parts, and that's kind of things that we have to be aware of as well. Because we're treating, yes, they're coming in for maybe one type of pain, but there's a whole scope and a whole big picture that we really have to pay attention to. And one of the reasons why I even wanted to have you on was because I've my experience in an acute care oncology setting kind of brought to light how many different types of cancers, how many different types of patients there are. And most likely, again, no matter the setting, you are going to come across someone who had possibly a history of cancer. And we need to be aware of all the different, whether it's the treatments they had or just the presentations they had because of the treatments or because of the surgeries or interventions that they did have. And I think I just keep saying big picture because we really have to think of the whole patient here. I want to get an understanding too. What is your, not necessarily opinion, but what do you think in your eyes physical therapists or even occupational therapists do? What would be your definition of like kind of our profession?
I think, I mean, I'm used to having even different subsets of occupational therapy and physical therapy depending on the circumstance. But I think by far, I mean, if I had to generalize it, they obviously optimize a patient's ability to carry out not only the things necessary in life, but also to do it in a manner that's either less painful, more effective, or optimized to kind of help their overall well-being. Now, being like personally working in academic centers in my 10 years of training, and then being in private practice in a community-oriented city, I can tell you that there's a humongous like range of how specialized the PT or an OT can be and how coveted that is. So like, just want people to know, listeners, like you can be exceptional at something to where everyone in town needs you to help with that specific thing. So I have like obviously PTO2 for my head and neck that get radiation and can't swallow well and have really trouble. And you also need speech path phonation and swallowing all this stuff. But then this gentleman with the brain radiation, there's a difference between whole brain radiation and depending on where the focal lesion is. So where I trained, I would know which physical therapist, like which angle to go if it's just a neurologic kind of rehab situation, or if I have somebody with Mets that radiation didn't totally help on one side of the hip, I need to really optimize the strength of the proximal muscles on the other side so that it's more compensatory. So it's nice to have these little niches with PT and OT again to be able to enable them to, because most patients are metastatic, right? They're mostly stage 4 that you can now help live for years with almost no disease. So that's where I'm really aggressive with wanting to get that PT-OT optimization, because what's the point if they can't go hunting? I was talking to a guy earlier this week. I'm like, you came in a year ago at 90 pounds and didn't even want to start therapy. You're like, this is my time, decorated military guy, 70s. And I'm like, you just went hunting with your grandson last week. And I was like, and you shot something. And I was like, and you're 30 pounds, 40 pounds more, And I was like, would you have believed it on what you thought, chemo was and this and that. And that was also with great assistance from PT, OT, and all that stuff to get him there. So it's, to me, that they're, absolutely instrumental. There's no purpose in what I do if the ailments are there, which no one can fix but you guys.
Yeah, and I think you probably summed it up so perfectly, and I appreciate that. And thank you for recognizing, what we can do. And that's also like another reason why I wanted to have various professionals on the podcast, because I think like you said, there's totally different like specialties or standpoints or things that the same profession can help with. I mean, same thing, everyone's an MD, but you can go into so many different types of or specialties. Just completely lost my train of thought. We'll get back to that. But I like also that you said you didn't say anything about like injuries, because I feel like that's a huge misconception, is that, oh, do they just send them to PT and OT just because, if you're in pain or if you have an injury? But there is a whole functional goals or just getting back to a quality of life aspect to it, which I think is super, super important.
Yeah, I guess that's an interesting point that you just made about myself. I guess that did surprise me when you just said that, because I was a big athlete when I was younger, gymnast and soccer and stuff. So I had to go to PTs often. It's so weird. I don't know at what point did I just change. Obviously I'm pretty, subspecialized, but that's very interesting. Yeah, you're right. I'm at a different place now on how I regard, how foundational that is. Wow.
I mean, it just shows like kind of, again, it's the patient population you're working in, and there is that big variety that it's needed, whether it's the neuro type rehab or, like you said, with more strength component, if it's like the hip compensatory strategies. I wanted to touch on too, like whether it's, I know you're more in an office setting now, right?
Mm-hmm.
Do you do a lot of like more outpatient referrals? Do you try to get people into more like an inpatient rehab component? Or if you have any other experience, maybe during like residency? I know you said internal medicine residency, but if there was just any collaboration while you were in those, like more of a hospital-based setting?
Yeah, no, I'm definitely still hospital now. Like I admit my patients, our practice is connected to the hospital. So every couple of weeks I round on and we have our own service, the Hemonc service. So I work very closely with the inpatient rehab as well. That is one of the biggest frustrations, I guess, or setbacks, is I'll have patients. I have another one, she's really bad breast cancer just everywhere and really debilitated from it. And I haven't, sorry, it's not triple negative. It's what's called HER2 positive. So now we have targets on our cancers, which are extremely effective, when back we didn't, and you just had general, cytotoxic, quote unquote, poison chemo. So yeah, give somebody that's really worn out, that they're going to get sicker. But now when it's targeted, it's like, it kind of sucks up front, but then the disease just melts away, and they have so much more strength and nutritional optimization once you get a control of the tumor with targeted therapy. And in this case, it's HER2. So I was stuck. She was really debilitated. It was a really late diagnosis, but she's young, like relatively, like in her 40s and 50s. So I was like, do I put it in inpatient? I got one dose in as an outpatient, and now the rehab was like really, 4 to 6 weeks to even get her to a place where she's even walking right, and she was working so full time a year ago. But at the same time, I have to get my treatment in, and obviously there's humongous setbacks with like you can't do treatments inpatient. I could go into insurance a gazillion times, but so then it's either
That's a
delay
whole
treatments.
nother
Yeah, I can't
sore
even.
thumb. I know.
Right. And so yeah, but I'm very familiar with those settings. So for me personally, with my cancer patients, it's difficult to do the acute or the longer term inpatient rehabs until I get into a place where I'm on top of the disease, it's metastatic, and I'm ready to take a break for them to do that. But and I'll tell you, like MDs, unless they really NDOs, unless they really delve into it, it's hard for us to know. I mean, obviously, like y'all are so well trained on that and the assessment on what's needed and stuff. I just see the end product and I'm like, this is great. Can I have this for everybody? And they're like, well, I think outpatient will suffice. I'm like, but the other ones did so well. And, so it's just amazing what y'all can do assessment wise and everything.
What do you think are some considerations that rehab staff can um, look for when they're dealing with either patients who are dealing with active treatments or maybe they're in remission now, just things that we should be more aware of when working with these types of patients?
You said in the inpatient setting or
Whichever setting,
any?
just in general.
I think by far with any cancer patient, like if I had a workflow as a PTOT, would be number one: is it metastatic or is it curative? And by curative, I mean stage 1 to 3 is generally all curative. So that means the treatments are going to end, and God willing, they're going to be in a remission, hopefully forever. So that's one way of orienting, and knowing too that their debilitation will probably be improved at least nutritionally or systemically, because the systemic treatment will be finite. It'll be over after 12 weeks, generally, depending on the tumor. And then versus stage 4, obviously, where you're like, okay, I know there's no end to treatments, right? So that's the number one I would think. Is it metastatic? What is it's called treatment goal? Is it curative or is it disease control? And then once say the stage 4s, you're like, okay, they're always getting treatment. They're always going to be kind of setback with either fatigue or this, that, and the other, and their ability they're not going to be golfing, but at the same time, they want to have a good time with their grandchildren. So then in the metastatic setting, you want to make sure their ADLs, activities of daily living, are really optimized, because that's a big stratifier on what chemotherapy regimens we can do or subject. Hate to say it, but it is sometimes like that, subject someone to, quote unquote, because you hate to do something that's just too much of a toll on their quality of life and their autonomy. So I would, in the metastatic setting, think that. And then the next step would be, do they have where are the Mets? I think that's very important. Do they have bone Mets? And if they do, now you're knowing what to be sensitive to or not. And kind of delineate what the pain is. Like pancreatic pain is radiating pain, even though they swear it's lower back pain. It's not because there's any musculoskeletal anomaly there. It's because the celiac nerve is conducting really bad lower back pain. So you need to know where they are. And then in the bones, obviously for physical therapy reasons. And then I think the presence of brain mets are very important. So that would be like a 3B or a 3C kind of thing on the workflow. Do they have brain mets, and are they getting radiation to the brain? Because then you can anticipate, depending on where the radiation is, what deficits are going to come, so that you can be ahead of the curve and really optimize and strengthen those things, because the right side of their body is going to get weaker down the line.
Yeah, I think those are really, really great. I also want to ask, because we're a 3-year doctoral profession, and even though we have a diagnostic criteria, I guess, that when we have a patient walk through our door, we're still taught on, which I'm sure you guys are as well, more like yellow flags, red flags of things that are more concerning, and knowing when to refer out. That's something that's like more out of our scope.
Mm-hmm.
So when you see patients who are coming in with newer cancer diagnoses, I know we're taught kind of the very minimal basis of like signs and symptoms to look for that could potentially lead to a more unfortunate diagnosis. So what would you kind of recommend? So I know you just kind of said like pancreatic could, radiate and become back pain. So what do you think are some quote unquote red flags that we can kind of look for in a clinic if someone comes to us, because we have direct access, so they might not have seen a primary physician before us, when they come in with maybe like night sweats or different types of pains that could be more of like, this doesn't seem like just musculoskeletal, we should really refer out.
Oh, that's a great question. Um, yeah, so I think systemically, or what we call, constitutionally, I think weight loss is a big one. So like my question is always when I'm getting referred somebody with, lymphocytes are elevated or whatever, um, have you lost weight and was it intentional? And at first they're like, well, I'm not, they're like, yeah, I lost 30 pounds. I'm like, how'd you lose 30 pounds? Well, I've been watching me eat a little bit. And they do some mild modifications and you're like, that's not enough to lose 30 pounds. So unintentional weight loss or a suppression or ablation of appetite are two very concerning things. Like a human body it should not ever not want to eat. That's a sign of physiologic stress. It's theorized that it's evolutionary. Like if you're in a pack and you're going around and there's, an animal that's ailing that has cancer or whatever, these stress hormones shut off your drive to want to eat or your appetite because it knows you're ailing and like you're going to reduce nutrients and produce from the pack so that they don't get as much while you're sick. So that's why the theory is those that were selected for were the ones that when you do have a problem, your reflex shuts down because then you won't hurt your community basically. So those are two concerning things: unintentional weight loss and loss of appetite. And then from there, I would say constitution, those are the two biggest ones. I mean, of course, night sweats are with lymphoma specifically, but outside of that, you don't get night sweats with, I guess, solid tumors and some of the more common cancers. And then on the physical part, adenopathy is important in lymph nodes. So, I mean, you nailed that. If you're, in a rural kind of setting and you're the only PT guy and a lot of people don't get primary care, like a quick, just, palpation kind of right by the pec, lateral to the pec and in the axilla, quick. I mean, you could know if you have lymph nodes there, as well as, I examine everyone there and on the neck and supraclav and periauricular, because those are all lymph nodes that are common sites of metastases. One very popular one that we worry about, I want to say it's Jane's or Saint Mary or one of those, is the supraclav lymph node right in the middle of that little pit. You'll feel a really hard lymph node, and that's usually a sign of like a GI primary, and I've had a couple of those now. But y'all, especially again rural where they don't have help, you just palpate just smoothly straight from the neck down into things. Takes 90 seconds, and you can definitely find a cancer in somebody. And lymph nodes in general, it's not medical advice, but they're very hard. They're not like rubbery like normal lymph nodes that are reactive. They're hard, like you feel it, and you're like, this is a rock. Just as a general rule. So yeah, on the physical exam, that, and then those constitutional symptoms I mentioned, and then balance is a big one too, like Romberg's. I'm sure y'all talk about that. Like, if they're not feeling their feet, they're having a neuropathy, it could be like myeloma and stuff, and then of course it could be like a spinal compression, as you'll know better than I do. So things like that.
Yeah, all great points. And yeah, I think there's obviously various presentations, various different diagnoses, and there could be a whole book written on different things to look for. But yeah, those are definitely some great key points. And I totally, when I did my acute oncology, I felt a lymphoma, and I can agree, totally hard. And I was like, not what I was expecting at all.
Right. Right.
Um, so for sure, very, very interesting. What has changed we're in a pandemic now, the past 8, almost maybe 10 months at this point, really? What has changed for you as far as working with your patients, having them come in, or are you seeing more late diagnoses, more end stage, unfortunately? Like, kind of, what have you been seeing?
Yeah, all of the above. A lot of stuff. It's settled down on the cancer part of it. I'm also a hematologist, or have a hematology specialty, so a lot of the heme stuff, which was considered elective, so like high white counts, low white counts, anemia that's not your standard iron deficiency. All of those are pouring in right now because they didn't quite take a priority, and a lot of those, not a lot, but not a small number, have been now like turned out to be leukemias or lymphomas and stuff like that, which in general, I mean, those are treated systemically anyway. The big miss is when a solid tumor leaves the primary site. But I had a good bit of that, had a good bit of difficulty getting restaging scans to not know if the treatment was working or not. So, I mean, yeah, all the stuff that you would kind of logically expect have definitely been present. The biggest thing I think emotionally is it's just not. It's so. I think. I mean, everyone's a hero that can combat this and get through day to day, but especially the ones that like don't have family or like the loved ones, their support. I think that's really, really hard, especially if they've had it for a year or whatever, and all of a sudden for a long time there. And still, I mean, you can't have your whole family in the room anymore. So it's like at first it was nobody, and now like I'm like letting one in, just when it's a end of life discussion and stuff. That's been really difficult. Is the lack of family being around and stuff, or a lot of families are saying not letting their mom, dad, whatever come to these events, the family stuff. We don't want you to get sick and whatever, but at the same time they're metastatic, so you don't know if there's going to be another Thanksgiving, and so all of that gets really tricky. And I take that as my responsibility as an oncologist. I'll call the family members and stuff, obviously with permission, to realign. Remember what our goal is and what our expectations are, because patients do really well when there's a remission, but then statistically, eventually cancer outsmarts the treatment you're on, and it's easy to forget that. So all that's been very tough.
Yeah, for sure. And I even think back to, I'm gonna just keep kind of repeating myself at this point, but like the acute oncology rotation that I had, and I was fortunate enough to, at least in my eyes and the family members' eyes, to make an impact on two patients who were more end of life, but the family was there the entire time, and I can't imagine these
Yeah.
patients not having their families by their side. Or like I know one patient he was a young dad and he wanted his 8-year-old son there all the time, and I can't imagine being like going through this, being stuck in a hospital because you're not strong enough to go home, and then now add a pandemic and you can't even see people who you like want to see every day. And I think just as clinicians, again, in various settings, we really need to be more mindful of that and provide maybe more so emotional support, because we can't have someone sitting next to us the entire time who can do so, that like knows the patient maybe better than we know them. And
Right.
I think that's going to be super important to just like really work on building those connections and hearing someone out and being more listeners and just being that shoulder, being that hand, because they might
You're
not
the
have
only one.
access to
You're
that.
the only
Yeah.
one in the room. Yeah, I mean that's the most humbling thing about doing what we do. And um, y'all, us, when we see these people, when we get to see people routinely and over, like it really can be the only sometimes thing of strength and encouragement and stuff. And I think that's why it's just very humbling. People are like, what made you want to do oncology? And then I'm like, because it's the most humbling thing. It's like every day you're just humbled by the people that you're seeing with courage twice as large as yours and strength and resilience, and you're getting to satisfy and provide something for them that's like intangible. If you're doing it right, if you care and you're compassionate, and I mean, what an honor! Like, how, I mean, like I don't. That's how. Why would you not want to do that? It's like
Yeah,
it's a
I
privileged
wholeheartedly
position.
agree.
Yeah, I feel very just honored, like privileged to be able to even be in such an intimate time, in my patient's life, and to have their trust to do that.
I want to also touch on that, just brings another thought to me, of one of the patients that I just mentioned. He was more end of life, and what I want to emphasize, how quickly things can change. You can speak from the medical standpoint, and I'll just touch on the rehab standpoint a little bit. So, um, he was a pancreatic cancer patient, came in for some medical complications. I remember evaluating him on a Friday. We walked up and down the hall. I was like, oh, he'll go home over the weekend. He's doing great. Come back on Monday, things start going downhill. So, from a medical standpoint, wasn't doing so great. 3 weeks went by, and he was just more and more debilitated, and we couldn't get him home on hospice. And I know my biggest takeaway was, by his final days, we went from just transferring from the bed to the commode at the bedside. And he was just so thankful that we can get him to do that little bit right there and then. But it's like I said, it was only 2.5. I don't even know if it was a definite 3 weeks. And that's how much it changed so quickly. So, from a medical standpoint, what do you think, no matter what the health health practitioner you are, what do you think is something that we need to kind of be considerate of or mindful of when we deal with patients who are perhaps on a more rapid decline?
That's tricky. You mean from any standpoint or from a physical therapy standpoint?
I guess whatever standpoint you want to take, really.
Yeah, I mean, I guess in a more of a macrocosm kind of principle, it's you don't want to take anything for granted, and I think that's why it's something like being able to give somebody their physical autonomy or independence and stuff. It's just important, and I don't know how much y'all see family members in the room or like at least associate with them, but a lot of times I'll have an adult daughter like 40s or 50s or son kind of like saying, don't do that, dad, don't do that, mom, don't let me do it, whatever. And I'm like, you're kind of maybe pulling away some of the things that they're wanting to be able to do while they still can, and that sounds morbid, but the same thing goes for Alzheimer's and dementia and all these other progressive diseases. So to be in a position to be able to help them do that, I think maybe communicating and asking that is very important. Like, it's easy in an inpatient setting to reflexively want to wipe or like take it off, the diaper, switch and whatever. But sometimes if you had like, hey, would you like to do this? Would you like, I'd be happy to do it. I want to do it, but if you want to do it, and then you'll be surprised, especially when I, worked at the VA hospital, like some veterans want to do that to the very end, like, and maybe by even doing these small things for them instead, it's taking their independence away a little early, if you think about it. So I think being sensitive again to any metastatic setting, I hate the fact that some tangent is like how like, well, it's stage 4 cancer, so they're going to pass away now one day anyway. So like, why even, I hate that because it still applies to everything else, like age in general or Alzheimer's and dementia, or all these other things that are quote unquote, everyone's terminal. I'm terminal. Everyone's terminal. So it's like you live with ailments, period. It doesn't matter if it's a stroke. It doesn't matter if it's whatever. It doesn't mean you should stop like enabling somebody to have their independence and strength and everything and care and ask them what do they not, want on brand.
Yeah, that's a great point. I love that. I want to switch gears a little bit on a more lighter, happier kind of note. Let's talk a little bit about how I discovered you, which was through TikTok. So, what you touched on this a little bit when we first started chatting, but what prompted you to make the TikTok? What is your goal? How is it going?
Yeah, so I know there's no video on this, but you can see my smirk, like, or just like, I don't know if it's a smirk, if it's a bashful smile, whatever. But I, I think you can tell I have this like weird kind of like whatever with it because my day to day is very, as I guess you can pick up on, is very sobering and serious and stuff, and I think that is what maybe precipitated this other side. To be honest, I started only because there was a year. So my wife was finished fellowship a year before me. So and we were still in the same state before I was away. So she went down and started practice with both our kids down there. So I was by myself for my chief fellow year, and I was driving back and down on the weekends. But anyway, the point is, it was free time that I didn't have while I was there. So I just opened the app. There was some kind of, I don't know, enthralling little musically kind of thing. It was an ad. I didn't even plan on posting at all, and that's what everyone says. But then I did at some point about something. I really like the anonymity of it at first because I'm like, nobody knows who I am. It's not like the people that follow me or see my video or anyone that knows me, like when you just join as a user, no one knows you. Like, and that was oddly liberating because, us like as professionals, you really want to have the trust and to some degree respect before they get to know you. And that usually happens anyway if you're genuine, but, you want to preserve that. So that this was the first capacity in a social media kind of way to be able to just kind of do my right brain, and some of the stuff was more sophomoric at first, and just silly antics being what I'm saying stuff without saying it. But anyway, so then one was viral, and it was just not cool. Like it was like a little at the end, like shirt comes off. It was just so like just gag. It's not on there anymore, so nobody looked for it. But and then it took off, and then I started like that one went viral, and then I started getting a lot of followers, and they're like, "Well, he's not medical, this and that." And then I had this like thing. I'm like, "Wow, like this is like I don't know if it's Indian philosophy or Eastern Asian or whatever, but like it's balance in the world. So like any too much of anything is not healthy. So like I was like having just like attention or like to do having followers in vain just doesn't feel good. Like it's like you're just receiving, like, you know, and you're not giving anything, right? So I was like, I got to balance that out, and I need to use this for something better or bigger than me, because that's hugely unproductive. And then so that's when I was like, I started teaching, and at first I started teaching about just kind of like, you know, I saw a lot of what my wife went through, is, you know, a blonde, blue-eyed, always smiling, always sweet doctor versus me, a male Indian, you know. And so I noticed how differently we were treated, how much easier things were for me. I mean, everything. It just was very obvious, the sexism in medicine right now, still rip roaring. If anyone disagrees with me, DM me. Because I'll like, I mean, I'm just so fervent about it. So I started with that, talking about kind of like that, and just, you know, microaggressive terms about, especially in healthcare, like man up, or, you know, all the stuff. I try not to use that because it implies that being a woman is not tough, and my boys are strong. I mean, we work out and everything, but they definitely, you know, they know mom is the toughest, because toughness. Anyway, so I can go on forever. But the point is, that's what I was doing. And then I was like, then I started at some point seeing comments about, you know, all that incorrect stuff about cancer, and it's just a money grab and all this stuff. I'm like, wow, like there is a big need. Like cancer is only in your life if you know someone with it, and otherwise it's just this completely nebulous, enigmatic thing. So I started shifting to education on that, and then more recently, I've been kind of on a big like patient empowerment advocacy kick. Kind of like ask, you know, I hate to say it, but in a lot of places in the country, most places, you have to share responsibility for your care now, because either the volume's too high, or, you know, the pressures from DC on how many a doctor has to see in a day, and the attention. Like, it's just, the healthcare system is far from ideal. And what that requires, I know the easy reflex is this doctor doesn't care, or they're not paying enough attention, or they just want money. But really, there's all these other circumstances that come to make for volume and whatever unmet needs in the community, et cetera, to where patients, I think, like, it just, and they want to know. Patients want to know. It's different than it was on, you know, 50 years ago, and they want to know about what these values mean and stuff. And you just can't explain that to every patient in a day. You just can't do it and meet the cost of paying all your front staff and all your, you know, the building fee, everything. So anyway, I'm sorry, I'm rambling, but now my videos are more like, hey, if you're anemic, like maybe ask your doctor about this, and like whatever, and this is why, and check out why the anemia goes this way versus another, and all this stuff, because then you have the information, and it makes the visit that you have now much more resourceful and higher yield, because you come with questions, and obviously your doctor's competent and totally can address them. So that's where I'm at now,
I love
with
it. A
humor.
lot of good stuff. Of course, with humor. And no more
Right.
shirtless TikToks.
No, yeah, that ended in, yeah, a long time ago.
I love it. That's great. What are your biggest takeaways from your role in the healthcare system right now, or like any tips for students that are listening, whether they're in the rehab setting or maybe even thinking about going to med school?
I think overall, I mean, number one, I say this pretty frequently, and it's because, you know, what I do, I have younger people that have just really unfortunate diagnoses with cancer and stuff. You really got to enjoy the process on whatever you're doing and how you're pursuing it. Like, if you're thinking, I just got to get to point B, and I just got to get through whatever school and get A's for the next 2 years, and then I just got to get through residency. Like, if you're not enjoying the time, it's really taking for granted the time that you do have on earth. And so I try to dissuade that. So even if that means like being okay with like not being prepared on 12 out of 12 chapters, but at least that 6 weeks of your life, like you took some part of it to enjoy and to remember why you have fulfillment and stuff. It's just vitally important. And again, I'm biased because I have young patients pass on me, and I myself, you know, I see it firsthand, but you got to enjoy the process. That's number one. Number two, find the reward and fulfillment during your schooling years, like in the little things, like teach your family members and your friends and stuff. Like when they have questions, if you enjoy that, and that's why you're in it, you'll get that fulfillment early. You don't have to be all the way, you know, practicing to start knowing if that's something that fulfills you. And if it doesn't, like, that's okay, you know. And I have a lot of people say, well, how do I get motivated to study for stat or for MCAT? I just don't have that motivation, this and that. And I'm like, well, sometimes, like, maybe we just need to think, like, is this what I'm motivated to do? And I say that not to say like you quote unquote can't do it. It just means that you may be really badass at something else that really does just inspire you, and that you mean well, and you can still have a tangent to that on enabling somebody or something in a different capacity. So like, it's never a failure if you're not motivated and you think you want to step back and seek out something that does inspire you. That much just might mean that you're just going to be exceptional at something. So that's an important reevaluation to make. And then, unfortunately, realize that with whatever you do, it's going to come with frustrations from the system. And I remember I kept hearing that, like, healthcare system and policy and insurance, that like it makes practicing difficult. And I just was like, what does that mean? I was like, I have no idea what that means. And what it means is you're going to see injustices. You're going to see people that came in at stage 4 that didn't have to be because they were a product of, having Medicaid or race or whatever it was. And that's going to be very visible. But then you're going to have patients you can't treat because insurance is taking too long. And now they're, getting sick to the point they can't be treated all because of their insurance, whatever. And then you're going to have other people that you're making really good gains in physical rehab and you're so excited and y'all are high-fiving saying, by Christmas, I'm going to have you walk into the bathroom. And then all of a sudden they can't show up again because of something that happened in healthcare. So those things are very hard. So be prepared for that. Unless you're callous, those things are probably going to hurt. And then also, when a patient family is crying and you want to be able to talk to them more, or like to help them after the rehab session's over or whatever, you're going to be probably in a position, including even me in private practice, or now you just can't sometimes. Or you do, and it's time less from your kids and when you get home. But if you make a habit of that, your kids get less of you. So the system is built to where you don't have the luxury of, usually it's tight spaces, tight intervals, and when your next appointment is and stuff. So just realize it takes a lot of kind of psychological resolve and security, which obviously they give you no exposure to or training during schooling,
I think those last 2 points were a great little ending to this. And I just kind of want to add to that too, because I agree, we don't get taught anything about that in school either. And that was probably one of the biggest, or one of the harshest realities I know I had to face in my first year out, because the platform that I have is a huge advocacy platform, whether it's for students or new grads, and I'm trying to help everybody kind of in this process. And I just feel like I personally have like a more of an advocating type of personality. So being in the hospital setting, I was like, what do you mean this patient can't go to inpatient rehab? Who do I have to call? Who do I have to chase? And they're like, I don't know, it's insurance. I'm like, what do you mean it's insurance? And it's just like barrier after barrier after barrier, when patients like really could benefit from whether it's inpatient rehab or some other type of medical component to, impact their quality of life. And it's like one of those things where you just have to every day try your best to help in that time that you have allowed, and hope that they can make enough progress in that moment to not face like such a barrier when they leave the hospital in this like kind of example. But yeah, just to add on to that, there's such a huge problem with their healthcare system, but I think it's also, coming from just the strict PT world, we have such cuts in outpatient settings, and I know like we all harp on it so much, and it's like to hear it also from another type of medical professional, I think is not heartwarming. That's not the right word, but just like to know that we're all
vindicating,
kind of, we're all
or
going through it.
validating.
Yeah, validating. I like that word better. Just we're all kind of being impacted by it. But it just kind of shows just how much more aware or more impactful we need to be in like the time that we have allowed.
Yeah, you nailed it. And I think I've never said this on a podcast or anything that I've spoken on, but I hesitate. But I do think, I don't know that the healthcare system and that exists today is necessarily like means well as far as like health. I think obviously it's bottom dollar, it's a business. That doesn't mean everyone associated with it is bottom dollar business. And I think that makes more of a responsibility of us as parts of an imperfect system to balance that other side out with compassion and commitment and care. And it is what it is. Like, and I think I get a lot of that on TikTok. It's like, well, the cancer world isn't that. I'm like, I agree with you. I understand that pharma companies are for profit, and I get all that. And I'm having to navigate those. I'm having to know whether studies are legitimate, or is it so marginal, but it's such a big cost that it's almost a money grab. I'm not going to do that. It takes me dancing, but all of us as individuals, as people that aren't, that the actual system, but we're just players in the system, we can balance that with compassion and care. And I think when people can accept the imperfection of the system, but say like we're all doing the best we can, hopefully. And if you're not, shame on you. But if you are, then we just deliver the best healthcare within the confines that exist today.
Exactly. Mic drop. I love it. All right. Where can people find you if they have questions, want to slide into your DMs, want to continue a discussion about anything?
Yeah, it's the same thing on Insta and TikTok. It's the OncDoc. It's TheOncDoc. And yeah, I'm on both of those mediums, and a lot of times not a lot of times, I did it once, but it was really pretty successful on a Q&A on my story on Instagram, and just y'all can ask and, get exposure on what you're doing, and I can reply that. And yeah.
Perfect. Alrighty, you guys have heard it here first. That was Dr. Sanjay Juneja. Thank you for coming on the podcast. I appreciate you.
Oh, I appreciate you so much and what you're doing. I hope we keep in touch.
Awesome. Thank you.
Thank you for listening to this episode of the All Things Physical Therapy podcast. Make sure to leave a review and subscribe to stay updated on new episodes. You can find more episodes like these on Apple Podcasts and Spotify. And to stay up to date, follow dpt.stuff on Instagram or go to www.dptstuff.com.